All right, so that I think is a summary of where we are in all of our housekeeping. And so we're going to move now directly into our program. And I have the pleasure of introducing our first speaker. So Dr. Paul Adamson is an infectious diseases physician and assistant clinical professor of medicine in the Division of Infectious Diseases at UCLA. His research focus is on improving the diagnosis and treatment of STIs. That's why he's here, with a particular interest in the intersection of STIs and microbial resistance. And as you can see from the title of his talk, particularly drug-resistant gonorrhea. So Dr. Adamson, take it away.
All right. Thank you so much for the introduction, and thank you for the opportunity to be here. I'm really excited to be here to talk today about drug-resistant gonorrhea. We're going to cover epidemiology, management, and future treatment directions. These are my financial disclosures, and these are our learning objectives for today. So we're going to talk about recommended and alternative treatments for gonorrhea. We're going to talk about the idea and the concept of resistance-guided therapy for gonorrhea. We're also going to talk a bit about pharyngeal infections and why these are more difficult to treat. We'll also talk about what to do if you suspect a cephalosporin treatment failure, and we'll also talk about two future gonorrhea treatment. So let's jump into the case here. So I wanted to start with this case. This is a 42-year-old heterosexual male who's presenting to the clinic with 4 days of urethral discharge and dysuria. 3 days ago, he developed these symptoms, and he reported having sexual intercourse with a female sex partner. He recently also returned from a trip to Thailand, where he reported having sexual intercourse with a female sex partner while there. So his exam is notable for purulent urethral discharge. A smear is done in the clinic. It shows 3+ inflammatory cells. A gram stain is done in the clinic and also shows gram-negative intracellular diplococci, like you see here in the picture. Treatment is given ceftriaxone 1 gram intramuscularly once and doxycycline 100 milligrams twice a day for 7 days. A urine test is sent for gonorrhea by NAT and returns positive. The urethral swab was sent for a culture that grew Neisseria gonorrhea in culture, and antibiotic susceptibility testing was performed. This is the antibiotic susceptibility testing profile that returns. So you can see intermediate, susceptible to penicillin, resistant to ciprofloxacin and tetracycline, high-level resistance to azithromycin, resistant to both ceftriaxone and cefixime, and susceptible to spectinomycin. This is an antibiotic that's not available in the US, but is used in some regions. So obviously very concerning antibiotic susceptibility testing profile here. So because of that, the patient's recalled 2 weeks later, comes back to clinic. At that point, all the symptoms has resolved, but given the antibiotic susceptibility testing profile, he actually received spectinomycin 2 grams IM. At that time, a urine test was again set for a NAT, and it was negative. The patient was recalled 3 weeks later, and at this appointment, pharyngeal swabs were taken for both culture and PCR, both of which were positive. And in the culture, the antibiotic susceptibility testing profile was the exact same as the initial infection. He denied any sexual contact after treatment, and because of the testing profile and the lack of sexual activity, there was concern for a treatment failure, and he received ertapenem 1 gram IV daily for 3 days. And so 3 weeks later, he comes back to the clinic. At this point, all the NATs and all the cultures from both the urethral and pharyngeal swabs were all negative, and they note that they were unable to contact the Thai partner. So of course, this was a case report of treatment failure that was reported back in 2018, and this made a lot of headlines. So this was this is what I call the clap heard around the world. So the BBC picked this up, said the man has the world's worst super gonorrhea. Washington Post said this is our greatest fear, highly drug-resistant gonorrhea. And The Guardian said this UK man has the world's first case of super strength gonorrhea. So I was coming through my training at this time as an infectious disease fellow, and I was very interested in STIs. And actually this case and reading about this case and really sparked my interest and is sort of how I became interested in drug-resistant gonorrhea. So drug-resistant gonorrhea is an urgent global health threat. It's listed as a red urgent level threat by the CDC, which is their highest threat level for antibiotic resistance. And the World Health Organization lists it as a high priority pathogen. So this is a list of pathogens for which antibiotic resistance is a big issue and for which new treatments are needed. And as you will see here in the next few slides, new treatments are needed because ceftriaxone has been our mainstay of treatment, but this is really under threat in a lot of parts of the world, specifically in the Asia-Pacific region. So there was some data here from Cambodia in 2022 that showed that 38% of isolates in Cambodia were resistant to ceftriaxone. Our team had a study in Vietnam that found 28% resistance to ceftriaxone. And this is followed up by 2 reports by the WHO surveillance program, one in Cambodia that found 31% and another from Vietnam that found 27% resistance. And then in China, there was a report that had resistance at 8%. That highline level percentage is a little bit misleading because there were a couple provinces in China that had resistance over 20%. So very concerning picture here in the Asia-Pacific region. But there have also been cases sporadically reported in Europe and the UK. This was an extensively drug-resistant case with possible treatment failure in Austria in 2022. This was a case of multi-drug resistant gonorrhea in France of 2022 with travel linked to the Asia-Pacific region. And then this was a detection of 10 cases of ceftriaxone resistance in the UK over a 6-month period back in December 2021 to June of 2022. And don't think it's just a problem for Europe and the UK. We have also had a case recently here in the US. This was in January 2023. You can see made the news and CNN here as a case of multi-drug resistant gonorrhea. This case report was in Massachusetts and it was recently published last year. And this was a very interesting case. So this was in August of 2022. It was in a heterosexual male who actually presented to a primary care clinic with urethral discharge. And the clinicians there actually sent a urine culture, which is not the usual culture that is sent for urethral discharge, but nevertheless, urine culture grew Neisseria gonorrhea. They did resistance testing and they found that it was resistant to ceftriaxone, cefixime, and azithromycin. Fortunately, this person was treated with guideline-directed therapy and was cured. Some follow-up on the case, they could not identify any link to international travel. And so there was some concern that this was potentially some locally acquired resistance. So they did a retrospective study of remnant PCR samples from gonorrhea tests, and they actually identified an additional gonorrhea case with a similar multi-drug resistant pattern in someone who had also been previously treated a few months back. So this is something that we're going to see increasing in the US, and so something to be aware of, to think about, and to have a framework to approach this if you encounter it. So that's what we're going to talk a bit about today. But first, I want to talk a bit about how did we get here? So this is how it started. This is penicillin. This is a CDC poster from 1944. Penicillin cures gonorrhea in 4 hours. See your doctor today. So it's incredible, right? We're treating gonorrhea with penicillin. And then this is a screenshot from the CDC website in 2023 that says that little now stands between us and untreatable gonorrhea. So this really is a story about Neisseria gonorrhea, the bacterial pathogen. It really has an incredible ability to develop resistance. And in fact, it's developed resistance to every single class of antibiotics that have been used for treatment. So this is a graph showing the year that a class of antibiotics was introduced on the y-axis, and on the x-axis is the year that resistance was detected. And it shows the number of years it took to develop resistance. So you can see in the 1950s and 60s, penicillins and tetracyclines had a decently long run before resistance developed. Ceftriaxone, it took 30 years before resistance developed. Whereas other antibiotic classes like ciprofloxacin, it was rather quick with 5 years until resistance developed. And we used to have a lot of options for treating gonorrhea. This is a CDC slide showing primary antibiotics used for gonorrhea treatment. And there was a number of different options available in the late 80s and 90s. But over the last 10 or 15 years or so, this has really been ceftriaxone as the mainstay of therapy and in increasing doses, so from 125 to 250 to 500. And antibiotic resistance in gonorrhea is increasing. So this is data also from the CDC gonococcal surveillance program showing resistance levels for different antibiotic classes here. This blue box here is showing the period of time where we used dual therapy for treatment with azithromycin and ceftriaxone. And you can see here quite high levels of resistance for Cipro, tetracycline, and penicillins, and much lower resistance for azithromycin, cefixime, and ceftriaxone. Zooming in on those a little bit here, you'll note just the change in the y-axis here, but in pink, this is showing increasing azithromycin resistance over a number of years, peaking in 2020. And this is ultimately what prompted the change in the guidelines to change away from azithromycin as a dual therapy. And you can see here cefixime and ceftriaxone resistance levels are quite low. They've been well below 1% for a number of years. So this brings us to the CDC treatment guidelines. So for uncomplicated gonorrhea infections of the urethra, cervix, and rectum, the treatment is ceftriaxone 500 milligrams IM once for people weighing less than 150 kilos. The dose is 1 gram for people weighing more than 150 kilos. And alternative treatments are cefixime 800 milligrams PO once and gentamicin 250 milligrams IM once plus azithromycin 2 grams orally once as alternatives. And as mentioned in the question stem, if you have not excluded chlamydia at the time of treatment, then doing doxycycline 100 milligrams twice a day for 7 days is recommended. And of course, partner testing and partner treatment is an important component of gonorrhea control, and it's something that we need to make sure we do. And also reinfection rates here are very common, so retesting at 3 months is recommended in the guidelines. One thing I find very interesting, and I wanted to bring up here, is that we've talked a lot about resistance, but interestingly enough, half of the gonorrhea isolates in the US are actually susceptible to all antibiotics here, which is really interesting. And I want to draw your attention here to ciprofloxacin. So here, ciprofloxacin resistance is in the range of 40 to 50%. So obviously it's too high to recommend ciprofloxacin as empiric therapy for gonorrhea. However, on the flip side, we could potentially be treating 50 to 60% of gonorrhea infections with ciprofloxacin if only there was a way to determine if it was susceptible at the time of treatment. So I want to spend a brief moment talking about ciprofloxacin resistance. And Cipro resistance in gonorrhea is rather unique for one reason, and that's because there's basically one mutation in the gyrase A gene, so in the bacterial protein, that confers resistance to ciprofloxacin. So I'm showing a really simplified schematic of this here. So on the left here, this is the wild type gyrase A, and you can see that ciprofloxacin is able to bind to gyrase A, exert its activity, and kill the bacteria through its antibacterial properties. But here on the right, I'm showing a schematic where there's a mutation, this S91F mutation in the gyrase A gene that modifies the gene in a way that Cipro actually can't bind to the gene. It can't exert its activity, and therefore the bacteria is resistant to ciprofloxacin. And this gene is associated with quite high quite high sensitivity and specificity for predicting susceptibility to Cipro. And this sort of, advanced this question of if you could rapidly determine the presence of this gene, could you predict susceptibility to ciprofloxacin, and could you use that in treatment decisions? So this was a question that was brought up in a clinical trial. This was a multi-site prospective trial that was done 2016 to 2018 that used this gyrase A PCR test to detect this S91F mutation, and it evaluated efficacy for ciprofloxacin 500 milligrams once to treat gonorrhea. They did follow up with microbiologic cure 5 to 10 days post-treatment, and they enrolled 211 participants who received both gyrase A testing and culturing prior to receiving treatment. And these are the high-level findings of the results here. And I want to draw your attention to the intention to treat arm and the microbiologic cure. So you can see for cervical, urethral, and rectal infections here, they achieved greater than 90% microbiologic cure. It was a little bit lower for pharyngeal infections. Now, going down to the per protocol analysis. So these were people who presented with with gonorrhea, had gonorrhea gyrase A testing, had cultures done who, if they had a susceptible infection, were treated with ciprofloxacin and then presented back to the clinic for tests of cure. And among that group, they actually achieved 100% efficacy across all sites for microbiologic cure. So this shows that if you can predict ciprofloxacin susceptibility at the time of treatment, you can actually treat with Cipro. So this sort of advances this idea about resistance-guided therapy for gonorrhea. And this is a concept that we actually use for other pathogens and antibiotic combinations. So if you've ever seen a blood test for Staph aureus come back, and it's a rapid PCR test that will tell you if it's an MRSA infection or maybe if it's vancomycin resistance, has vancomycin resistance. This is something we use for staph. We use this in gram negatives as well to detect extended spectrum beta-lactamases or carbapenemases. And this is really how we pursue TB treatment. So we test for mutations that are present, and we determine our treatment based on the presence or absence of those different mutations here. And gonorrhea lends itself quite well to this in terms of gnats, because most infections are actually diagnosed by gnats. So you could do it as a reflexive test from a positive test, or you could do it simultaneous detection at the same time you're doing the PCR. This also allows for potentially using an oral treatment option, so that perhaps there may be some cost savings there as well to avoid people needing to come back to the clinic for injections of ceftriaxone. And then this would potentially conserve our last line of therapy. And actually, this is in the guidelines. So the US and the UK and Australia have permissive use of ciprofloxacin in terms of treatment. Most people don't know this, but in the 2021 CDC guidelines, there's a section there that says that if a patient's asymptomatic, if the treating facility is able to perform the gyrase A testing in order to identify Cipro susceptibility, then oral Cipro as a single dose could be administered. And there are some commercial assays that are available in some regions. This is one example, the Resistance Plus GC test that's made by SpeedX. And this one allows for simultaneous detection of both gonorrhea and gyrase A testing at the same time. In the US, this is primarily done through laboratory developed tests. This is where your laboratory sort of internally validates the test and offers it to clinicians within the system, but doesn't advertise it broadly. And this is usually done as reflexive testing, so there can be a 1 to 2 day lag to results, so depending on how your lab processes this. And then currently there's no FDA cleared assay for doing this in the US, but hopefully that will change in sometime in the near future. But that's kind of made it a little bit complicated to push resistance guided therapy for gonorrhea just yet, because there is no kind of current FDA cleared assay. Okay, we talked about uncomplicated gonococcal infections in other sites, and I want to talk a bit here about the pharyngeal infections. So the CDC makes slightly different recommendations for pharyngeal infections. It's the same dose of ceftriaxone as the other infections. However, here they list no alternative treatments, and also they make a recommendation for a test of cure 7 to 14 days after initial treatment using either a culture or a gnat. Depending on the scenario, you might do both. So what is it about pharyngeal infections that makes this sort of special case? Well, we know that pharyngeal infections are harder to eradicate than urogenital or rectal infections, and there's sort of a combination of factors that contribute to this. One is there's these commensal Neisseria species. So these are oral bacteria that make up part of your normal oral flora that can actually be a reservoir for resistance. So they persist in your body. They can pick up antibiotic resistance elements from other bacteria or from the environment. And they can actually pass these resistance elements on to gonorrhea. And we actually think a lot of resistance in Neisseria gonorrhea actually was exchange material from these commensal species. So this is, and the commingling in the oral environment is how we think that a lot of this might occur. The other reason is for reduced penetration of antibiotics into the site. So this can be both reduced penetration into the tissues of the oropharynx, but also this can also be reduced penetration into the oral secretions or saliva. And it's possible that the antibiotics don't achieve the same high level in the saliva as they do in other compartments. And this is important because infections in the oropharynx, the bacteria tend to be adherent to the mucosal lining. So you really need to get antibiotics kind of into the mucosal lining or into the secretions to exert their effect. And this is a really important site because this is a very common site in all the treatment failures that have been reported in the literature, all involve the pharyngeal site. So it's why CDC pulled them sort of separately out into the guidelines as a reason to monitor for tests of cure. So I did want to mention tests of cure here. So its purpose is to identify asymptomatic persistent infections, to identify resistant infections, and to reduce transmission of those resistant infections. If anyone here has done tests of cure for pharyngeal gonorrhea, you'll know there's a number of challenges. One is actually getting people to return for tests of cure. So in a lot of studies that have done, the return rate is quite low, so less than 50%. And this is even when it's recommended and there's nudges and follow-up with patients to get them to come in. It's difficult for people to want to do. I think a lot of infections are asymptomatic, so folks maybe don't feel as motivated to come back for their tests of cure. There's also the question about timing. So this is a graph on the right that's showing the clearance of gonorrhea RNA after treatment. And you can see here that the median of 3 days is how long it took for 50% of people to clear RNA infections. But I want to draw your attention here that in order to get greater than 95% to clear their infection, it's actually at 12 days. And this is for RNA, which is a little bit more unstable in the environment than DNA. So if you're using a DNA-based assay, this might actually be a little bit longer than this here. So this was a multi-site CDC study that involved several different sites in their surveillance programs, and they did tests of cure. They found positive tests in about 5 to 10% of those who returned. They said about a third were due to this remnant DNA. So this is an infection that's there, you give treatment, it kills the bacteria loses its DNA, the DNA persists in the environment, and then it's detected by these very sensitive PCR tests that can cause, in this case, a false positive test. And a theme here is that reinfection is very common, so about a third of these were due to reinfection. And they did note in their study that 15% were due to treatment failure. And then just to note, there was no cephalosporin resistance detected in these. These might have been people who received alternative treatment regimens or perhaps received inadequate dosing of medications, which is why they assigned those as treatment failures here. So there are some challenges for tests of cure. But now that we're talking about cephalosporin treatment failures, I want to cover a definition. So this is defined as the persistence of gonorrhea infection despite cephalosporin treatment. And when to suspect this? Well, if symptoms develop or symptoms persist despite receiving adequate cephalosporin treatment and there's no ongoing sexual contact, this is when you might think of it. Of course, it's also important to rule out and treat other infections that might be contributing to those symptoms. Another time is if you have a positive NAT that's done after treatment and without any ongoing sexual activity. I put an asterisk here at the 7 to 10 days. This is a CDC recommendation, the 7 to 10 days, but as we saw on the prior slide, some people might push that out a little bit further on the order of like 10 to 14 days after treatment, just to avoid or to reduce the number of false positives. And then, of course, if you have a culture that's positive at test of cure, this is really when you should start thinking about a potential cephalosporin treatment failure. Okay, so if you suspect a treatment failure, what do? So first, you want to confirm the history. You want to take a really good sexual history to learn about any ongoing sexual activity and potential exposures. You want to talk about any travel history, maybe to a region where there's resistance is more common. You also want to cover antibiotic treatments that people might have received and doses that they received. You want to obtain swabs. So this is really important. You want to get swabs for both gonorrhea PCR testing as well as culture and antibiotic susceptibility testing. And then the CDC guidelines here for suspected treatment failure. Again, because most treatment failures are actually just reinfections, the CDC treatment guidelines here actually just suggest giving guideline-directed therapy again, because this is usually a reinfection. However, if you have a high suspicion of a treatment failure for whatever reason, or if they're not able to receive ceftriaxone, then here, and you want to pay attention to this is a treatment failure alternative therapy, is this dual therapy with gentamicin 240 milligrams IM plus azithromycin 2 grams orally. So important to remember that. And I think one other thing that's really important here, I can't stress this enough, gonococcal culture and antibiotic susceptibility testing is really, really important. Cultures can be hard to do. We don't usually do those in clinical practice, but they're really important, especially when you're considering a treatment failure, because this is the only way we can do antibiotic susceptibility testing. And antibiotic susceptibility testing is the only way we can determine if it's resistant to ceftriaxone or other antibiotics. And it might also be able to determine what antibiotics you can give. So I can't stress this enough. Very important for us to do. We used to send for antibiotic susceptibility testing, we used to send to the CDC lab, and I know a number of people have as well. And some people might have heard the news that unfortunately the CDC lab, the gonorrhea reference laboratory, was actually just closed and shuttered. It's really devastating news in the gonorrhea field, and it's going to make it really challenging to continue to monitor antibiotic resistance in gonorrhea in the US. So it's quite a loss to the community. There are alternatives to sending to CDC. You can actually, you can send both cultures and antibiotic susceptibility testing to Quest and LabCorp. They can do an e-test for ceftriaxone, cefixime, and azithromycin. You can also work with your county and state public health labs. Depending on where you practice, they can also do some of these susceptibility tests as well. There's also a resource here from the National Network of STD Clinical Prevention Training Center that has a list of resources and labs that can do susceptibility testing, and they have some coordination by regions, so you can check that out. I included the link here. And then also, if you're considering a treatment failure, you want to make sure to work with your local public health department, as well as consider reporting to the CDC. The CDC does have these links for treatment failure consultation forms. This is there are links in the most recent STI treatment guidelines, and I just included a screenshot and a link here of what the clinical consultation form looks like. They'll collect some information about the case and then contact you to discuss it. So really valuable resource here. Okay, so we spent a lot of time talking about resistance and treatment failures, and I hope I gave you a good framework here, but I want to end on a little bit of bright news here. And this is about new treatments. So there are a few new treatments coming in the pipeline, and I want to cover a few of them very briefly here. So the first one is gepotidacin, and this is really hot off the press. This phase 3 randomized trial was actually just published last month in April. And this is a antibiotic. This is a first-in-class. It's a triazosinaphaline antibiotic, and you give it as an oral dose, 3 grams twice, 10 to 12 hours apart. It was evaluated in this phase 3 trial for urogenital gonorrhea. It was a non-inferiority trial with a 10% margin, and it was compared to ceftriaxone 500 milligrams plus azithromycin 1 gram, so dual therapy. And in the microbiologic intention to treat arm, they found the efficacy to be 92.6%, and this was compared to 91.2% in the dual therapy arm, so it met its clinical endpoint here. There was a phase 2 trial of this drug that was tested, that was reported years ago, and in that trial, there was actually some resistance that was detected that was potentially concerning, and so what they did here for the phase 3 trial, they actually went to an increased dose of the medication. And in the phase 3 trial here, they did not have any issues with resistance, and resistance mutations were not detected. So that's really reassuring news. And this is actually, interestingly enough, was just FDA approved for uncomplicated UTIs in March of 2025. So it's going to be available in the US for uncomplicated UTIs sometime in the summer of this year. And I mentioned this, I don't want people to have a takeaway to go around treating gonorrhea with gepotidacin just yet until we have any kind of clinical guidelines that recommend it. But I do mention this because, as we've talked about the story with gonorrhea, developing resistance to every antibiotic, there is some concern that now that it's being approved for other indications, and if its use sort of increases, the potential is there that resistance could potentially develop in gonorrhea. Again, just to be clear, there's no signs that that's happening. There's no data to suggest that it has happened or will happen imminently, but it is something we will need to monitor and make sure we pay attention to. The next antibiotic here is zoliflodacin. So this is also a first-in-class antibiotic. The dose given here is at 3 grams oral dose once for urogenital gonorrhea infections. It completed this phase 3 trial. It was a non-inferiority trial with a 12% margin, also compared to dual therapy with ceftriaxone and azithromycin. And this phase 3 trial was done in multiple countries, some with high levels of antibiotic resistance and gonorrhea. And this was evaluated in a microbiologic intention to treat, and it met its clinical endpoint, which was reported as 90.9% as compared to 96.2% in the dual therapy arm. And I will note that this was actually, it's not been published yet in a peer-reviewed journal, but there was sort of the high-level findings were presented last year at the ESCMID Global Conference, and this shows it's the microbiologic intention to treat for urogenital infections, as well as the evaluable subset here. And then just to note, this was in the FDA fast track status. I mean, it's anticipated that approval will arrive some point in 2025, though we don't know exactly when. So stay tuned on that. And on that note, I want to thank everyone for their attention and time. I hope you learned something, and I'm happy to take any questions.
Great. Thank you so much, Paul. That was fantastic. Really great summary of the risks, and I think great to see there's some hope for the future. So folks have put in some great questions. So I'm just going to start from the top, but I will say a few folks have put in really great questions. I think there's been a request for some of you to maybe resubmit with your name and your institution so that we can make sure that we intro your question appropriately. So the first question was actually one, Paul, that I also had. So Jared Sell from Westside Family Health in Wilmington, Delaware. And you got to this partly, but maybe just to make sure that we're really clear, because standard of care for most of us, I think right now, right, is NAT testing. So that's our standard screening. So when would you be sending samples for culture, as you mentioned, that may be harder to get to, but for culture to assess for gonorrhea resistance? Like in a case, when are you doing that? And I might even say, to add to that, you mentioned obviously test of cure for pharyngeal, right? Not for urogenital. So when are you doing further testing? And obviously in this question, particularly for potential resistance.
Yeah, no, it's a good question. It's something that comes up clinically quite often, and it's a good question. I think it depends on the clinical scenario. I feel like personally, when I do it, it's if somebody had some exposure in a part of the world where resistance is more common, I'm a little bit more concerned about resistance. And so in that case, if somebody came in with genital discharge, I might send a culture right off the bat. But I agree, most of the time I'm also diagnosing these through NAT and not routinely doing cultures. I will say for people who have persistent symptoms despite treatment, that's really when I start thinking about sending a culture. So I'm maybe not thinking necessarily about multi-drug resistance just yet, but it makes me think that I want to have a culture to get some more data to drive this. I will mention though that urogenital cultures are much easier to, or the culture yield for urogenital infections is much higher than pharyngeal and rectal infections. And so it can be quite challenging to get really good pharyngeal samples for sending culture, and hard to do rectal cultures as well. So in those cases, it might be if there's some resistance that has been reported in the community, or if I had someone who came and said that their partner had told them they had a resistant infection. I didn't really know what to make of that at that point, so I sent a culture then. It ultimately didn't grow anything in culture, but I would say basically the take-home point for me is to do it based on travel history and persistent signs of infection that have persisted despite treatment. I would really kind of reach for a culture in that point.
That's great. Excellent. All right. So the next question, I think probably is not surprising to you. So this is from Sam Dubin, who is at Health Plus Hospitals in New York City. Can you speak to how doxy-pep may impact gonorrhea resistance and potential changes to clinical guidelines that may result if we continue to see potential risk of increased resistance?
Wow, fantastic question. It is an active area of research. So this is, so I will say what we know now is that there has been some efficacy against gonorrhea in the doxypep trials. It sort of depends on the level of resistance. So, in the first trial in France, they actually found no difference in gonorrhea reduction. So it was not protective against gonorrhea. The doxypep trial in the US, they found that there was some reduction in terms of gonorrhea. And then the second trial in France also found that there was some modest reduction in gonorrhea. But it's typically associated with the level of resistance that we see. So in the US, tetracycline resistance is on the order of about 40%, but there's some data to suggest that's actually increased quite rapidly over the last couple of years. And so it remains to be seen what that's going to look like. So it's possible, I would say very likely, that we will lose any protection against gonorrhea in terms of doxypep. The big question about doxypep and gonorrhea is whether or not it actually selects for resistance in other antibiotics. So one big concern is that the isolates with ceftriaxone, with ceftriaxone resistance in the US also carry high level resistance to doxycycline. So there's this idea that if you're using doxycycline and it's actually selecting for doxycycline resistant gonorrhea cases, those actually also are the ones that perhaps are more likely to carry ceftriaxone resistance too. So it could inadvertently select for strains that carry ceftriaxone resistance. That's a concern. I would say it's not been shown yet in any trials to have the case, but it is in kind of an active area of research. But for now, I would say doxypep works at a modest extent against gonorrhea, but we will very likely lose that in the next, hard to say, but in the next few years is my guess.
Yeah, great. All right. I'm going to tie two questions together here. So a question from Katrina Victoria, who is at Western Wisconsin Health in Baldwin, Wisconsin, asked a question about the case. And I actually had the same thought, which is ultimately you talk about the patient being diagnosed, but then they're brought back for pharyngeal testing. And Katrina is asking why they were brought back, like in just thinking about how we should navigate these cases. Was it because they were reported to be symptomatic, or was it because of something that you came up with, that you identified in the care? And then a follow-up question, just because it does get to the pharyngeal, right? The mention of the pharyngeal reservoir is how are we going to respond to this? So Antonia Altemeyer from Dartmouth, New Hampshire, kind of mentioned, are there new drugs or new approaches given the pharyngeal challenges? I would even ask, has anyone considered some sort of a topical as an adjuvant to systemic in that setting? So trying to tie two of these together regarding the pharyngeal disease.
Yeah, no, great question. So this is fun to talk about. So that case that I presented actually just pulled from the case report. And so I think what happened in that case is that the person came back and the clinician, I imagine, saw that susceptibility testing profile, got really scared, retreated with spectinomycin. One very interesting thing about spectinomycin, though, and this is not, we don't have it in the US, they use it in some parts of the world still, but it actually doesn't work very well against pharyngeal gonorrhea. So my thinking is what happened is that probably the public health department in the UK was involved. They saw that the person got spectinomycin because on that list that was the only thing that it was susceptible to, which is fine that they gave that. And then I think what happened was they probably said, well, we never checked pharyngeal infections. Given that this is such a concerning isolate, we should probably bring them back and make sure they don't have a pharyngeal infection as well. So that's sort of my reading between the lines in that case report of why that person was brought back so many times. It was just such a concerning isolate that was what prompted all that. I would say in usual routine practice, you don't necessarily need to do that. And then the question about pharyngeal infections is really interesting. We don't have a lot of data on things that work well. I would say ceftriaxone works fairly, it's like kind of the gold standard that everything's compared to, but it also doesn't eradicate all infections, as we've seen. Some places are giving higher doses of ceftriaxone in order to, get greater penetration in the oropharynx. And there has been some studies on looking at mouthwashes like, Listerine, to see if that can treat pharyngeal gonorrhea. They've not been so promising yet, but perhaps there's some kind of like topical antibiotic approach that we could look at in the future that would, kind of help in terms of local treatment of gonorrhea, and given the challenges of penetrating the tissues, perhaps a topical treatment is needed.
Yeah, great. All right, so a question now from Dr. Rosado at the University of Utah regarding the two new antibiotics that you mentioned. And, in terms of when would you consider? I mean, as you mentioned, right, you got to be careful with these. One is expected to be approved by FDA coming. But when would there be a recommendation for using these new antimicrobials as they're coming forward into the clinic? Would it just be for initial treatment of cephalosporin resistant cases? And would they be recommended, for example, in the pharyngeal disease, given that it sounds like a reservoir and potentially a place where resistance may actually develop?
Yeah, my thinking is that we shouldn't be using these as first line therapy in the U.S. And I think again, when it's approved, my guess is it's going to be reserved for cases where ceftriaxone resistance is documented or shown, or maybe if someone can't receive ceftriaxone and they have some other resistance pattern that precludes other antibiotics there. But my guess is it's only going to be used in drug-resistant cases in order to kind of conserve that as a therapy that we could use in the future. And I will mention, though, that there are, we've done some research in this area, there are some mutations that are associated with, like, for example, zoliflodacin resistance that have been found in gonorrhea isolates, like in the early 2000s and even more recently, that are sort of out there. So they're not at very high levels by any means, but it just shows that the ability to develop resistance is there, and so the more we use it, the more likely it will, or I guess the faster it will happen. And so I think that they're going to reserve this as last line therapy after ceftriaxone is not available, and I think that also will go for gepotidacin as well.
Yeah, it makes a lot of sense. So, and one more question that's kind of more of a technical question, which is regarding getting antibiotic susceptibility testing from sources maybe other than urogenital. In this case, they were asking about getting resistance testing in someone from synovial fluid, and we're told that this is actually not testing that can be done in their laboratory. This is from Dr. McNamara at Gunderson Health System in La Crosse, Wisconsin.
Oh, interesting. Yeah, so it doesn't matter the site as long as it grows in a culture, then they should be able to kind of isolate out isolate out the bacteria. And once they have it growing in the lab, you really can perform susceptibility testing on any isolate you have. It doesn't necessarily matter the location. It might be, though, that they weren't able to do susceptibility testing on any isolate at that lab, which is not uncommon. And so that's why I included those resources for people that want to send susceptibility testing.
Great. Great. Thank you so much, Dr. Adamson. And thanks for all the great questions. I will hand it over now to Dr. Landowitz.